give you just a little bit of background about my experience and the credentials that I bring to you today. The best experience really is being a lifelong Vermonter and having been born and raised on a dairy farm and had a lifetime of understanding the range of opinions amongst Vermonters and how we live our lives respectful of different opinions and living together in community. This room is filled with people that I know from various parts of my life, and some of us stand on opposite ends of the issue, and I respect their opinions and assume that they also respect mine. My work experience is quite varied. The first part of my career was spent in private practice in Middlebury, where for about 18 years I ran a private practice. We provided a range of care from OB services and childbirth to end-of-life care. And basically over the course of that career, I began to see more and more an unmet need of my patients that had serious illness and advanced illness, and the model and the care that they needed was not fitting into a traditional busy family practice, and I felt that I needed to do something different to meet the needs of those patients. So in August of 2009, I started a practice called Partners in Palliative Healthcare. It was really a pilot project for something that I hope will come to pass again in the future, and basically this model was one other physician and myself caring for individuals who's had advanced illness and whose desire was to receive all of their care in place. So rather, if they were in a nursing home or at home or assisted living or wherever they were living, their goal was to live well and to have their end-of-life care provided where they were without having to go to the hospital. It was an incredibly enriching experience. Over the course of 2 years, I would say that from the patients and their families' perspective, it was wildly successful. We cared for a little over 200 people in total. 120 of those people died over the course of that 2 years. 119 of them died where they were living, a statistic that I am incredibly proud of. The one person who did not die where they were living was a person that we met in the hospital, and he unfortunately was too sick to get home. So the nature of that practice was really intensive hands-on care. It was highly coordinated. I worked very closely with the Home Health Agency, with Project Independence and other local service agencies, and we really advocated for the best possible end-of-life experience for our patients, whether that meant weeks, months, or even years. Unfortunately, it was not financially viable in our current fee-for-service model, and I think we heard a little bit from Dr. Hart about the limitations of our current model, and hopefully that's going to change. But essentially the practice couldn't support itself, and I was blessed to have another opportunity, which I had previously turned down, but then accepted. And that was a position where I currently am, where I am in a tertiary care center, working 100% of my time doing inpatient palliative care consultations for people with serious and life-changing illness. And I also spend a significant amount of my time teaching medical students and residents. So the goal of my job now is really to meet with patients and their families, and often sit down with multiple specialists and to help establish what we call goals of care, which means taking a patient's situation, their wishes and their hopes, putting it together with the medical reality that is ahead of them, and developing a comprehensive treatment plan that respects all of that reality. So, over the course of my time, and I think the first time I was here testifying was probably 10 years ago, when I felt like I had a lot of experience in rural Vermont caring for people in a private practice, and I was a strong supporter of the concept of end-of-life choices then, and the more experience I have, the greater my depth of support for this legislation and my very strong, I would say even at times desperate need to have this legislation passed so that we can meet the needs of all Vermonters, and not all of them are active patients. So here we are talking about a piece of legislation that perhaps 50 or 100 years ago wouldn't have been needed. Excuse me. And the reason is that death today is very, very different than it was even one generation ago, let alone 2, 3 generations ago. Our medical system has had wonderful successes in keeping people from dying suddenly. We have safety measures that keep us from dying in car accidents. We have cardiac interventions that save us from having our first heart attack or dying from it. We have chemotherapy agents that treat first-line and second-line cancers and help people live well for many, many years. What that means, though, is that people are living longer and developing multiple chronic health problems, so that the end of our life now looks much more complicated, and in fact is sometimes hard for doctors even to see that it's coming. So our modern medicine, and especially our specialty-focused medicine, has trained doctors to be really good at something we want them to be good at, which is looking at a patient, identifying a problem, prescribing a medication or a test or a procedure to fix the problem. And as we get better and better at micromanaging down there, we sometimes forget to step back and look overall at the patient and holistically at what is really happening with the patient, when are some of these problems not fixable, and when is it time to look at different things. So despite everything that we can do, life, of course, is still a terminal illness. We all will die. Some of us will die before we're ready, and some of us will die unexpectedly. So our death looks different today than it did several generations ago. We have new tools to treat our underlying problems and illnesses, and I believe now is the time for new tools to treat our end-of-life experience. We have seen a lot of advances in symptom management in palliative care. We have several different pain medications that can treat things like pain and nausea and shortness of breath. We have advanced technologies that help people live with increased infirmary. We have wheelchairs, we have oxygen concentrators, we have ventilators that people can live on at home. We have made tremendous advances in our ability to support people with advanced illness. But despite all of those advances, we still have situations where a significant number of people near the end of their life will experience suffering. And I think that it's worth spending a couple of moments honoring and respecting and understanding the word suffering. Suffering is suffering, as Eric Cassell, one of the great leaders in the field, said. It is incredibly, deeply personal. It is specific to the individual. My suffering is my own. I may ask you for help. I may benefit from your support as I suffer, but nobody understands my suffering. Some people find suffering meaningful for various and different reasons. Some people find suffering manageable, but some people find it unacceptable. Suffering can take many different forms, and we often focus on the physical forms of suffering, things like pain, not being able to breathe well, loss of autonomy and dignity. We've heard a lot about that. Loss of the ability to do the things that we used to do that gave our life meaning. It is very complex. But again, suffering is suffering and unique to the individual, and modern medicine, despite all of its new fancy tools, cannot always address this suffering. We definitely have made a lot of progress in trying to improve people's end-of-life experience. We have heard about the many benefits of hospice. In my practice, in primary practice, in my palliative care outpatient practice, and certainly in the practice that I do now, I'm a strong advocate for early hospice referral to help people manage all the aspects of their suffering and all the aspects that it might take on. But death is still very, very hard work. And despite all of the things that we have to offer, we cannot always alleviate people's suffering. I'm really often taken aback, but I've learned not to be surprised by the universal themes that happen toward the end of life. One of the questions that I often ask patients is, if it was possible that your time could be short, what would be important to you? And universally, whether the patient has a lot of resources or little, or they're Republican or Democrat, or have a deep spiritual belief, or are atheist, or have been chronically ill or acutely ill, people almost always want very similar things, and they generally fall along three principles. The first is that they want to be comfortable. And my interpretation of comfortable means that they don't want to suffer. So I will remind you again about the complexity of that word suffering and the fact that people don't want that. They want to be comfortable. They want time with their family and loved ones. And the vast majority of people, not all, but the vast majority of people prefer to die at home, surrounded by their loved ones. And I hope it's not a surprise to you that unfortunately, the vast majority of people sitting in this room today will not get that very simple wish. Because illness, because managing illness, because healthcare, because living with disease has become much more complicated. As part of my job at Fletcher Allen, we run a 24-hour hotline for what we call our rural palliative care network. So these are providers in our service area who are out there providing care for patients, and they can call us if they have questions or are stuck in symptoms. And just this week, I had a call from a provider seeking some guidance and support for a patient who had suffering. And this patient had clearly had a terminal illness. She had actually lived well through the first line and then second line chemotherapy. She was grateful for the care she received. Her life was extended, but she developed another symptom and went for further follow-up, and it was determined that there was no additional treatment that could be offered to treat her underlying cancer. And she was placed on hospice and given a prognosis of months to live. She is described as fiercely independent. She is not afraid to be dead, but she is suffering with her dying. Her pain is well managed. She does not have an acute infection that's likely to end her life in the next days, but she is suffering. She has friends that come and visit, but she is not comforted by her friends. She does not have any interest in talking to a spiritual chaplain or a psychologist about her suffering in hopes of helping it. She is not interested in medications to try to take away what is not depression, but what is grief, very different things, at the end of her life. This is exactly the kind of patient that has the potential to benefit from the legislation that we have an opportunity to pass here in Vermont. These are the patients and these are the families that I hear about, that I see daily, some of whom are experiencing symptoms that cannot be well managed. Those patients and those families are not here today. They're not here because their energies are elsewhere, their grief is elsewhere, and they are overwhelmed by the issues of living with daily life. And so I'm here on their behalf to speak to you on my experience. And I definitely want to emphasize that in adding this end-of-life choice, we are simply expanding our range of options for people that choose to use it. And I am deeply comforted by the fact that no physician, no provider, no patient will have to make use of this legislation should they choose not to. To me, it goes back to those fundamental basics of being a Vermonter and respecting differences and living in community together. I do want to talk just a little bit about some of the alternatives that we hear about sometimes and why this legislation might not be necessary. And I know a couple of other folks have addressed this, but I hope you will allow me to just speak briefly on my experience. So one of those is voluntarily stopping eating and drinking. So this is a process where a patient who is nearing the end of their life, who decides that their life no longer has meaning and they want to hasten their death, can do so by stop taking in nutrition and hydration. The process generally takes about 2 weeks. I have to say that more and more I appreciate what you probably already know, which is food has a very complex and central role in our lives. And especially when it comes to families and friends and gathering and being together in community, I could talk all day about the complexity of food. And sometimes for patients with advanced illness, eating, even in small amounts, is one of the last pleasures that they still have. And asking a person to give up this in order to hasten their death is not an easy thing to do. In my many years of experience as a palliative and hospice physician and as a primary care physician, I have seen one patient do it and do it very well, I would say, without conflict and with a relatively peaceful death. I have another individual who I am helping guide right now who is beginning this process. And she and I have had many conversations about what it will entail, who she will want to know, how she will inform her family, what her God may think of this process. She happens to know that I'm a strong supporter of this legislation, and she reminded me the last time I saw her, because she reads the newspaper every day and she knows what's going on. And she wanted me to tell you that she wishes this wasn't her only choice, that she wished I had a pill, that she wished that I could do something that could allow her what she wants and hopes to have, which is a peaceful death with her family at her bedside in her own home. So she's working on this, and her family knows, and they will be present if at all possible. But as the process unfolds over 2 weeks, there are likely to be things that happen that make it very challenging and difficult to be a part of, and it really takes a very dedicated patient and a strongly supportive family, very special circumstances to make this be successful and peaceful. The other alternative that we have heard about is the issue of sedation, and I want to speak just a little bit to that. Some people are familiar with the older term terminal sedation. We now use a broader term called palliative sedation. And just to confuse the issue, sedation can be partial or temporary or ongoing. And in any of these cases, we're generally speaking about somebody who has uncontrolled symptoms, and those symptoms are usually physical. Breathing trouble, uncontrolled nausea, seizures, pain, what have you. It's generally done in the hospital setting, but can be done in the home setting. And it is usually done in a situation where the patient, because of their condition and the medications that they have received, are not fully able to participate in the decision making. So the decision is being made by the providers and by the family members. And I can tell you that it is gut-wrenching and very difficult for families to do so. Even families that have talked about end of life before really always want the patient to say what they want and the patient to be in control, but it's not always possible. So in this situation, the patient is given medication, they are unconscious in a deep state of sleep, and we maintain that level of unconsciousness until they die from their underlying disease. If we think there's something about the situation that was temporary, as Dr. Hart alluded to, sometimes patients will come back out of sedation, but most times it is maintained, again, until the patient dies of their underlying disease. And as we know, what the death certificate will say is that the patient died of their underlying disease, which is in fact the truth. I wanted to also speak just a little bit about the concept of double effect, and the sense double effect really came about as a means to reassure providers, nurses, and physicians that when you give a medication, like morphine to alleviate symptoms, and there is an unintended consequence, and actually people think this happens a lot more often than it does, then because you're giving it with the primary intent of alleviating suffering, if there is an unintended consequence, then we accept it. And again, when we use this, the death certificate states that the patient died of their underlying illness, which is in fact the truth. I, as a long-term supporter of this bill, and for all of the years and the efforts that I have put into this, am mildly distressed by the current Senate bill that exists, because I believe it does not significantly change medicine. It does not provide the important safeguards, the deliberate process that patients should go through in order to be sure that their rights are respected, that all options have been explored, and that circumstances that might lead to a physician-assisted death are done so only when absolutely necessary. I believe that S77 actually perpetuates what I've heard alluded to as the wink and nod. The wink and nod phenomenon really describes what some people talk about, which does happen probably in an ongoing basis across the country, where a physician gives you medication for something, and then the idea is that they might wink and nod and say, well, if you take too much of this, you might have something happen that you don't want to, like you might die. And then the idea that the patient in their own time, and without the physician's involvement, can simply take the medicine and end their life peacefully. Wink and nod is not about open, honest communication. It is done under the table. It is done covertly. It does not involve family by definition. It does not involve an open, honest, and thorough conversation about what happens. And my concern about S77 is that it, if anything, could perpetuate this reality without explicitly naming what we're talking about and addressing it. Sorry, I thought I heard somebody call my name. So this bill, properly amended to re-include the very carefully laid out safeguards that come from Oregon, and as we've heard many times, many years of experience that this legislation works and works well, is what I support, and I hope that you will practice. So I guess I would just like to summarize by saying that In all my years of experience, I believe that most Vermonters want to have options available to them. And if they want nothing else, they want to demedicalize their end-of-life experiences, because, of course, when death is near, it really becomes less and less about doctors, and it becomes more and more about patients and what they want and what their families deserve, and about addressing their suffering on a deeply, deeply personal nature during a very, very precious time. And what I want to do is to help patients have that opportunity to see death not as something that we have to be afraid of, to have a range of options available to them to meet their suffering, whatever it should be. And as others have alluded to, pass this legislation, have it in our back pocket, and then carry on doing the very important work which I have chosen to dedicate my career to, which is helping patients with serious illness live very, very well until they die. Thank you.